Neonatal Emergencies and Transport, Part 2. The areas that we're going to cover here are going to be pulmonary pathologies and congenital heart defects. First thing we're going to talk about is persistent pulmonary hypertension in the newborn, clinical syndrome in which the pulmonary vascular resistance is elevated in the presence of changes in the pulmonary vessel reactivity. And very simply, this is going to be pulmonary artery hypertension in the newborn. So your pulmonary artery increases contractile force, more back pressure. Essentially what we get from this is we get the right side of the heart that enlarges or becomes hypertrophic. Results in sustained fetal circulation, which in the case of the fetus, the venous ductus that comes from the placenta, and the way, if this is all pressured correctly, we should start getting lower pressure on the right side. In this case, the pressure increases on the right side. It causes problems with oxygenation, it causes problems with perfusion. Ductus arteriosus and foramen oval remain open, which doesn't allow for appropriate circulation. The ductus arteriosus allows for collateral circulation between the input from the lungs and the aorta, so it allows for collateral circulation. Commonly associated with severe hypoxia, Meconium aspiration syndrome, and congenital diaphragmatic hernia. Clinical presentation mirrors many of the signs and symptoms of the congenital heart disease. Many may be difficult to assess in the aeromedical or ground transport environment. You're going to have to kind of know the diagnosis before you can spot this or assess this. Management: maintain oxygenation, maintain an alkalotic state by administering sodium bicarbonate, because they're going to be in respiratory acidosis and metabolic acidosis from hypoxia. Give nitric oxide, and this promotes vascular dilation, which the pulmonary artery would make it larger. Keeps pulmonary perfusion pressures closer to normal. Also closes vascular structures. So if we reduce the pressure on this and have a lower pressure on the right side, the foramen oval and things like that can go ahead and close for us. Magnesium sulfate is one of the things that they can use as a pulmonary vasodilator in the newborn. Meconium aspiration syndrome. Meconium expelled prematurely in 10 to 15% of all deliveries. Only 2 to 10% will aspirate the meconium in the lower airways. Meconium aspiration can obstruct the airway and or may contribute to an activation of the alveolar surfactant. Surfactant is going to be important because it's what keeps the alveolar sacs open. No known preventative strategies. Nasopharyngeal and endotracheal sectioning before the delivery of the thoracic cavity may limit the amount of meconium aspirated into the lower airways. And this is a picture of as soon as the head presents, quickly mouth, oropharynx, and hypopharynx. About a 10 French. No catheter smaller than a 10 French either should be used. It probably won't pick up the meconium because it's thick and viscous. Following delivery, after delivery, if there's a great deal of meconium present, the trachea should be intubated and any residual meconium removed from the lower airway. Transient tachypnea of the newborn, or TTN, also known as wet lung or type 2 respiratory distress syndrome. Self-limiting process. It auto-resolves within about 48 to 72 hours from birth, caused by delayed clearing of fluid in the lungs. Management: ensure adequate oxygenation. Give antibiotic therapy. That's in case we don't want to get a pneumonia. Give antibiotic therapy until sepsis and pneumonia are ruled out. Infant respiratory distress syndrome, or IRDS, affects about 10% of all preterm infants, rarely seen in full-term infants. Results of a lack of pulmonary surfactant. Causes atelectasis, increased work of breathing, ineffective gas exchange because the alveolar sacs will not stay open, hypoxia and hypercapnia or increased CO2 levels. Infant respiratory distress syndrome continued here. Signs and symptoms include tachypnea, shortness of breath, accessory muscle use, sternal retractions, grunting, and nasal flaring. Respiratory arrest from muscle fatigue, hypoxemia, and acidosis may occur. Management: ensure adequate ventilation and oxygenation, and administer exogenous surfactant or artificial surfactant or man-made surfactant. So this is infant respiratory distress syndrome. Decreased amount of surfactant leads them to decreased lung compliance, and we get collapsing of the alveolar sacs, atelectasis, increased work of breathing, PO2 drops. On this side, we'll kind of look at all of this. Right to left shunting occurs. Pulmonary and peripheral vasoconstriction because we need to increase the output, increase pulmonary artery pressure, decrease pulmonary blood flow, decrease surfactant, which makes it even worse. Poor peripheral perfusion, and then decrease arterial blood pressure. On this side of it, increased work of breathing, decreased ventilations, increased CO2, which leads to acidosis, which leads to this down here. Pulmonary and peripheral vasoconstriction is compensation, and it kind of is a bad cycle. So we need to get ahead of this. Artificial surfactant is a way. Oxygenation, be sure that we oxygenate the newborn well. Congenital diaphragmatic hernia. Complications in which the bowel protrudes into the thoracic cavity through an interruption of the diaphragm, usually a result of congenital abnormalities. 85% of all congenital diaphragmatic hernias occur on the left side. Mortality rate on these hernias are about 40 to 60%. Herniated abdominal contents prevent full lung expansion in the affected side of the chest or the hemithorax. Pulmonary compromise ensues. You may even see this if a child or a newborn has been ventilated under BLS methods, and the person ventilating gets a little excited. They blow up the stomach, it pushes up on the diaphragm, the lungs won't expand well. Signs and symptoms are going to be respiratory distress, unequal lung sounds, scaphoid-shaped abdomen. Management: ensure adequate ventilation and oxygen, insert an NG tube, conduct a gastric decompression. If there's any air in there or there's any contents in there, we need to remove those so that we can get full expansion of the lungs. And the definitive treatment on this is going to be the surgical repair of the diaphragmatic hernia. Congenital heart disease overview. Incidence of congenital heart disease in the United States is approximately 8 per 1,000 live births. About 40,000 neonates born each year with a heart defect. Many congenital heart defects are subclinical. Defects can be abnormality in volumes and or pressures in the atria or ventricles, mixing of venous and arterial blood, inadequate cardiac output, and poor systemic perfusion. Neonates can have multiple defects at once. We'll talk about tetralogy of Fallot. Left to right shunt. Now, this is a condition in which oxygenated blood shifts from the left side of the heart to the right. Defect is considered acyanotic. High pressures on the left side of the heart prevent unoxygenated blood from the right side from entering the aorta and systemic circulations. It also increases the pressure on the right side, which is problematic if we're trying to oxygenate returning blood in the lungs. Atrial septal defect, commonly result of a foramen ovale non-closure, or they have a patent foramen oval. Oxygenated blood from the pulmonary veins enters the left atria. The higher pressure on the left atria compared to that of the right produces a volume shift to the right side, eventually causing right atrial and ventricular enlargement. Got a picture here in just a second. Signs and symptoms of this are going to be commonly subclinical. Clinical significance relates to the size of the defect. It actually how big the oval is. Rarely congestive heart failure might develop. Management gives supportive care, and obviously they're going to need a surgical repair of that atrial septal defect if it does give us clinical problems. Very simply, increased pressure. This is the atrial septal defect right here. The higher pressure mixing oxygenated and deoxygenated blood comes into the right side, so it lowers the cardiac output on the left side. And because of the higher pressure, this part of the heart responds as a muscle would, which it gets bigger, which causes a hypertrophic right side of the heart. Atrial and ventricle can both become hypertrophic. Ventricular septal defect. Defects in the ventricular septum allows blood flow between the ventricles. Can cause a left to right shunt of blood, pulmonary hypertension, changes in the pulmonary vascular beds where we actually exchange gases. The size of the defects determines the clinical significance. A small ventricular septal defect produces a small left to right shunt, little pulmonary vascular congestion, maybe a little chamber enlargement, and is really difficult to diagnose without actually getting an echo. Large ventricular septal defects. Pulmonary hypertension develops. Signs of the left ventricular overload, congestive heart failure develops. We get a backup we get pedal edema from this. We get a backup on the low pressure side, and now the increased capillary pressure causes an increase in afterload. They may have high systemic vascular resistance on this to the point to where they start to develop pulmonary edema. This would be from the left heart failing. You're always going to fail into the previous container. Signs of left ventricular overload, congestive heart failure develop. Can present early or late. Early presentations typified by global ventricular enlargement. Late presentations are typical by equal left to right and right to left shunting or the mixing of blood. Results of this are going to be an equal or near equal peripheral pulmonary vascular resistance and systemic vascular resistance, which isn't going to allow for gases to exchange. Signs and symptoms: respiratory distress, fatigue, diaphoresis at feeding, history of poor weight gain or weight loss, and congestive heart failure. Management of a ventricular septal defect. Ensure adequate oxygenation. Treat the congestive heart failure when present. Repair surgically, and that would be the definitive treatment on this. And the ventricular septal defect would be right here. This would allow high pressure, and on this side, this is going to actually, if they keep it long enough, it will allow the right ventricle and right atrium to respond because they're going to get larger because of the higher amount of pressure and resistance. It's going to cause pulmonary artery hypertension, which will equalize the pressure. Now, this is kind of a rough drawing, but alveolar sac way down at the end in the lung tissue. Well, alveolar sac would have been on the lung side, but the vascular side that runs all the capillaries across this, the capillary pressure is going to be higher, which will not allow for diffusion to occur, low oxygenation, inability to load the red blood cells that are coming back. Patent ductus arteriosus, a condition characterized by failure of the ductus arteriosus to close after pulmonary circulation has been established. Patent ductus arteriosus allows for flow of the blood from the aorta to the pulmonary artery. Causes of this are going to be pulmonary hypertension or pulmonary artery hypertension and myocardial hypertrophy. So the muscle itself has become so large that it's inefficient. Size of the defect and the amount of blood flow determines the clinical significance. Signs and symptoms: difficulty breathing, tachypnea and tachycardia, bounding pulses, widening pulse pressures, and fatigue at feeding. Management gives supportive care, administer indomethacin. Indomethacin is a type of IV NSAID that can be given. The action inhibits cyclooxygenase and prostaglandin pathway, which is going to decrease swelling in this area. And then if we use a prostaglandin inhibitor, this will allow us to keep the prostaglandin is what keeps a patent ductus venous arteriosus. So what this is going to do is this is going to decrease the chemical signaling and hopefully close it. Pulmonary artery into the lungs. And this is where our ductus arteriosus is. To where before we're born, this allows for collateral circulation because we are fed oxygen by the placenta. The lungs have never expanded yet, and the holes are open, allowing for collateral circulation. Obstructive defects. Quick overview here. Complete or partial blockage of blood flow, commonly caused by a structural deformity. Signs and symptoms are secondary to the cardiovascular structures that are involved. Aortic and pulmonary stenosis. Aortic or pulmonary valve narrowing. Blood flow is impeded in this. Ventricular pressure is increased. The ventricles enlarge. Post-stenotic vessel dilation event. So even after you've dilated this vessel out, that it could go back to a stenotic state. Signs and symptoms: respiratory distress, tachypnea, tachycardia, weak pulses, hypotension, and fatigue at feedings. Management: give supportive care, conduct oxygenation, proceed with pharmacological management, undertake balloon angioplasty, and this is going to like balloon out those vessels, or valvuloplasty. Now whenever we see this, you'll kind of see thickening here would cause aortic stenosis. So this would be require more pressure to open up this aortic semilunar valve. And the same way on the pulmonary side, pulmonic stenosis. You have a semilunar valve here as well. If it's stenotic, then it would eventually cause the right ventricle to become larger. Coarctation of the aorta. This is characterized by narrowing of the aorta near the distal aspect of the aortic arch. This increases left ventricular pressure, it increases left ventricular workload, and it causes the heart to enlarge or give you left ventricular hypertrophy. Signs and symptoms: tachycardia, bounding pulses in the upper extremities with thready or absent pulses in the lower extremities, and then fatigue at feedings. Management: give supportive care, administer prostaglandin, treat congestive heart failure when present, and complete balloon angioplasty or surgical resection, and that would be the definitive treatment. Prostaglandins are used in coarctation of the aorta. The drug keeps the ductus arteriosus open, and this provides a bypass for the blood flow around the constriction until the coarctation is repaired. And this is coarctation of the aorta. Very simply, it's just a narrowing of the aorta. So the venous ductus arteriosus would be somewhere around here and would allow patency of this. Now until this is fixed, this will allow for some collateral circulation and a decrease in pressure. This ends part 2. And if you have any questions, feel free to contact me. Name is Roy Smith, roy.smith@redlandscc.edu or smith@imsa.net. Thank you.